Explaining the death of a patient to their family is a very difficult and humbling experience, and one for which traditionally there has been little training. Explaining to families that the person they love has died, while still on mechanical ventilation, while still warm and with their heart still beating, is even harder. This can be a confusing concept, even for healthcare professionals who work in intensive care. We have all stumbled during these challenging family conversations, and you can find yourself using terms such as essentially dead or legally dead, as if there are different states of being dead, or stating, wrongly, that it is only the machines which are keeping them alive. If we struggle, is it any wonder then that the public can be confused? A survey carried out in Northern Ireland in 2013 found that nearly 50% of those surveyed thought that maybe you could, or they didn't know if you could, recover from brain death. This misinformation is no surprise, given that media reports frequently confuse persisting coma with brain death, and even the BBC will report brain dead man dies in hospital. It is for this and other reasons that in the latest Academy of Medical Royal Colleges Code of Practice for the Diagnosis and Confirmation of Death, the terms brain death and brainstem death were abandoned. Instead, the Code of Practice simply talks about the diagnosis of death. Recommendations in the Code outline the different criteria doctors should use to diagnose death, either by circulatory criteria or neurological criteria, depending on the clinical scenario of the patient. In this guide, we are covering the diagnosis of death using neurological criteria. But how is this best explained to families? There is no perfect answer, as the individual circumstances, family expectations, and clinician personalities will all play their part. I find that an ABCD approach has served me well clinically over many years, and a similar framework can be helpful when explaining the diagnosis of death using neurological criteria to families. A is for accuracy. Be truthful about what you know and what you don't know. This is more difficult than it sounds. Obviously, one always wants to be accurate, but what can get in the way of accurate communication is poor planning, and this can lead to muddled messages. Take the time to plan the conversation with the bedside nurse and with a specialist nurse for organ donation, even when donation is not yet a subject ready to be raised with the family. This will allow the clinical situation to be accurately clarified and serve as a rehearsal for the words you're about to use. Planning also allows common themes for good communication to be considered, such as the setting for the conversation, the chair layout, and who needs to be present, both from the clinical staff and from the family. Accurate explanation of the diagnosis of death using neurological criteria can be achieved if you keep sight of the essential message we want families to understand and accept. That is, that death is suspected, and that there will be tests carried out to confirm or refute this suspicion. A good way to check and support family understanding is through the deliberate use of summarising moments. This is particularly useful if there's been a long monologue of information giving, or a new topic is about to be introduced. Watch the family's reaction carefully when you summarise. When the family do ask questions or make statements, always acknowledge and reflect on what they have told you. B is for brevity. It is known that during times of grief, thinking slows. It is very important that the pace of the conversation slows to meet the needs of the family. Silence is an essential tool to help achieve this. Do not fill the silence with your own voice. That time is for the family. Long silences can sometimes feel very uncomfortable for the clinical team, but this conversation is about helping the family understand and accept their loss. It's not for our benefit. A good rule of thumb is that after any major statement of fact, for example, when you explain that the patient has died, this should be followed by silence. This will allow time for the devastating news to be processed by the family and allows them the opportunity to ask questions. The more you talk, the more likely the accuracy of your message will be lost, the more likely that confusing terms and concepts will slip in, and the less time the family will have for achieving understanding and asking the questions that are important to them. C is for clarity. As doctors, sometimes we just assume that after we have spoken, everything is perfectly clear to the family. In the conversations we are talking about, the bedside nurse and the specialist nurse for organ donation have an important role in continuing the conversation with the family long after we have left the room. That is why it's so important for them both to be present for our family conversations, as this allows them to build on and explain further, if necessary, our messages. What we can do to help ensure clarity in our communication is use simple and unambiguous language, avoiding technical and medical jargon. It is important that at some point the word death or died is used, rather than euphemisms such as passed away. This helps families to understand the essential message, that the tests are being undertaken to confirm if their relative has died. The use of visual aids can be extremely helpful, especially as some people are more visual learners. This can be achieved by showing the family the CT scans or by drawing diagrams. The James Cook Hospital in Middlesbrough have a relatives information leaflet that they give to families to help aid their understanding. One of the most powerful ways we can help clarify the diagnosis with a family is by allowing them to witness one of the 2 sets of brainstem tests. We would recommend the second set of tests as ideal for this. This will also demonstrate your profound transparency and openness to the family, which can help facilitate their trust in the diagnosis of death you are delivering. D is for delivery. The style of your delivery will be very personality dependent. Nonetheless, it is the tone of your delivery and how you made the family feel that is more often remembered by families rather than the words that you use. A doctor who can be accurate and clear, as well as being sensitive and empathic, will long be remembered positively by the family despite their tragedy. 3 simple suggestions can help. I've already spoken about the power of silence. Good use of silence and allowing the family the opportunity to talk will go a long way in letting the family know that you are listening and working to their pace, not yours. It's okay, and it's right to say that you are sorry for their loss. This is not an admission of wrongdoing, but a simple human acknowledgement of their grief and a way of expressing your sympathy. You will deliver your message more effectively when you work within a multidisciplinary team. Allow the bedside nurse and the specialist nurse for organ donation to support you. They can be picking up on and ready to respond to the non-verbal signs from the family that you may have missed as you concentrated on the words you were saying. But even after watching this video, always be yourself and always be genuine. This level of honesty and openness can be personally very challenging. But remember, the key transaction that is occurring between the family and you is not knowledge transfer, but the transfer of trust. The family, even if they witness the tests, will not become experts in the diagnosis of death using neurological criteria, but they should be able to trust that you are.